I'm going to speak for just a few minutes, uh, very briefly, on the need to be thyroid vigilant and the need to be thyroid aware. This will be the outline of my talk. After a brief introduction to certain aspects of epidemiology, I'll go on to autoimmune thyroid disease being commoner in women, and I will also look at a couple of case studies just to set the tone for the rest of today's meeting. So this is the editorial I wrote with Professor R.V. Jayakumar when we wrote the founding editorial in the Journal of Thyroid Research and Practice. Is that the sheer magnificence of thyroid diseases in India coexists with ground realities such as the patient's purse and affordability and health conditions of our country. And this is even more true in today's milieu, where a pandemic is ravaging across the country. At the same time, the non-COVID illnesses like diabetes and thyroid aren't really going away, and that has compounded the problem. So this is a paper I published in the Indian Journal of Endocrinology and Metabolism called the 8-City Study, where we looked at the prevalence. But the important question when we are addressing gynecologists is that how many young women potentially planning pregnancy could have hypothyroidism? And this is a paper I published with my former trainee, who's now a well-known endocrinologist in Madurai, Dr. Kumaravel. And we looked at 1,292 women aged 18 to 25 years. What we found is that the TSH was normal in about 87.5%. It was above 10 in about 1.3%. TSH was 4.5 to 10 in about 9.7%. And it was below 0.4 in a small number. So as many as 9% of women potentially planning pregnancy might have a borderline TSH, and as high as 1.3% of women planning pregnancy may really have overt hypothyroidism, which means a high TSH and a low T3, T4. Or here, we've just looked at a TSH more than 10, so we have not really looked at T3 and T4. So if you look at the undetected burden of hypothyroidism, it's very common, 3.5% overt and 8% subclinical. And if you look at hyperthyroidism, it's again not very uncommon in our country. Again, in the 8-city study of thyroid dysfunction, we found that this was in about 5,000 patients in 8 cities of India. We found that subclinical hyperthyroidism was present in about 1.27% of the population, and overt hyperthyroidism was present in 0.72%. So really not very rare. And if you look at thyroid nodules and thyroid cancers, what is known is that this is studies from Dr. Tandon and Dr. Marwa from Delhi. And this is from our own little paper. And 9 out of 100 people actually have a thyroid swelling, and 1 in 1,000 may have thyroid cancer. But the important point to note here is this is in the post-iodization stage. So India as well, in our 8-city study, we found that 88% of people were taking iodized salt. And India is more or less in the end of the transition stage from iodine deficiency to iodine sufficiency. So while earlier pioneering studies looked at iodine deficiency as an important cause of hypothyroidism, iodine deficiency is not a big problem now, probably, quote unquote, we don't know. But iodine sufficiency is there. And there are hypotheses that whenever an iodine deficient population suddenly becomes iodine sufficient, the iodine which is taken up by a very hungry thyroid gland may cause the thyroid gland to release antigens, and those antigens can cause a transient increase in thyroid autoimmunity in a population, and that will come down over a period of 10 years. So we don't know whether iodine sufficiency has led to a temporary increase in hypothyroidism or autoimmune thyroid disease in the population, but not to forget that iodine supplementation is probably the single most important public health strategy and the universal iodization of salt in preventing maternal-fetal morbidity due to iodine deficiency, preventing cretinism, neurological cretinism, mixed cretinism, uh, uh, and also mental retardation. So I've come to the first little bit of my talk, which is I looked at the introduction. I showed you data that approximately 1 in 10 women planning pregnancy might harbor a thyroid disease, and they might harbor it undiagnosed. So that's why I don't believe in universal screening of thyroid function tests in all pregnant women, but I certainly believe in purposive thyroid function screening. For example, if a woman comes to a physician or a gynecologist and is planning pregnancy, doing a thyroid function test for them. Now, autoimmune thyroid disease is commoner in women compared to men. And this is data from the HCD study where results suggested that in men, the prevalence of subclinical hypothyroidism was 7%, and women it was 8.7%, and the p-value was statistically significant. Women also have a higher prevalence of anti-TPO antibodies, and women also, this also was statistically significant. The prevalence of hyperthyroidism was notably not very different in women compared to men, suggesting that hypothyroidism is probably the more importantly, more common in women compared to men. So therefore, if you want to look at numbers, the odds ratio is 3.3%, 3.3, which suggests that women are at a threefold higher risk of developing hypothyroidism compared to men. And particularly women in the age group of 46 to 54 seem to have the highest prevalence of anti-TPO antibody. This is from our data of 5,376 people. Well, the study had some limitations because the very nature of the study, which used health camps, may have brought sicker patients because of a selection bias. So these numbers may be a little higher than otherwise, but it's important to note that. Now let's look at two case studies before I end my presentation. So the first case study, I'm titling it as "All is Well That Ends Well." So this is a quote from William Shakespeare, which says that all is well that ends well. This is a 29-year-old lady, a pregnant lady, a nurse. She lived in the UAE and came to see me after her visit to India. But in the UAE, she went to a physician, and it was found that the T4 was high and the free T4 was normal, and the TSH was 0.2. Now, we are all aware that the total T4 can be falsely high in pregnancy because of the thyroxine binding globulin, but the free T4 is normal here, the TSH is 0.2. No symptoms or signs, so leave alone this patient. But what did that physician do? That physician in the Middle East started her on propyl thiouracil 600 milligrams per day. She took it for 2 months, and when she came to me, she came in the 6th month on propyl thiouracil and came for a second opinion. Of course, we stopped the medication, and what happens if carbimazole or propyl thiouracil or methimazole is given to normal mothers like this in high doses? Well, the answer is really nothing much. So initially, you can see the free T4 was 1.3, and after the physician had started 2 months of anti-thyroid drugs, it was 1.1. The free T3 was 156, and after 2 months, it was 122. Gone down a little bit. The TSH was 0.2 and it became 0.9. In this patient, the TPO and TSH receptor antibodies were negative. So note that sometimes amniotic sampling may not reflect fetal status, and relative maternal fetal contributions are doubtful. Fetal blood sampling has got some complications. So in this particular patient, you could see that there's a fetal goiter. The pattern of blood flow was central. I realize I'm talking to gynecologists, so not really an expert on this topic, but just to highlight that practicing thyroid is often an interdisciplinary management where we talk to gynecologists talk to us, and we decide what's best. So the bone maturation was actually normal. Fetal movements were normal, and this was a goiter image. And you can see that a central versus a peripheral flow. In hypothyroidism, you have a peripheral flow. There's fetal bradycardia in the fetus. The bone maturation is slow. There are jerky fetal movements. So here, a mother with normal thyroid functions was given 600 milligrams of propylthiouracil, which crossed over to the baby, caused a fetal goiter, but luckily did not result in fetal hypothyroidism. And you can see that 2 months of antithyroid drugs didn't change, and we stopped the antithyroid drugs and just followed up. Sometimes it's good to do nothing at all. And that's what we did. We did nothing at all. And we just observed. We found that, yes, the free T4 went up a little bit. The free T3 went up a little bit. The TSH remained the same. And the mother was healthy. The baby was healthy. And a healthy fetus was delivered. So that's the end of my first case, which is titled All's Well That Ends Well, after William Shakespeare. And my second, so therefore, it's important to note that TSH receptor antibodies may be tested in certain cases of Graves' disease. My second case is called mother versus son. In other words, this is a case where I say that the mother and son don't agree in thyroid function tests. So these are, again, going back to the previous slide, these are indications for fetal ultrasound in pregnant Graves' disease. In pregnant women with Graves' disease, previously the TSH receptor antibodies more than threefold or difficult to control Graves' disease, you can do fetal ultrasound. In this case, we did the fetal ultrasound because patient was on propylthiouracil high dose, a normal mother, and we wanted to see what's happening from the baby's point of view. My second case is titled Mother and Son Don't Agree in Thyroid Function Test. This is a picture. Sorry to, this is not a very evidence-based slide, so I'm indulging myself here and maybe indulging you also, your time also. This is a picture of Mother India, and you can see that Nargis Dutt, who acts as Mother India here, is really looking aggressive and full of energy here. In this picture, maybe it's winter, skin's a little dry, face a little puffy. And in this picture, you can see that there is some evidence of a goiter out there. So again, this is not an evidence-based slide. Sometimes these virtual meetings can be very tedious. So I'm just trying to wake you up a little bit. This has nothing to do with the case I'm presenting. So let me go on to my case. Now, this is a 26-year-old lady who came in her first pregnancy. She came to me in her 7th month and she had classical features of thyrotoxicosis. The free T4 was 2.8, the TSH was low, the TSH receptor antibodies were positive. It's a classic Graves' disease, thyrotoxicosis, T4 high, TSH low. We treated her with anti-thyroid drugs and it was managed uneventfully. But what we found is that, again, going back to when should you do a TSH receptor antibody in a mother, that's done when there is present or past Graves' disease, previously high TSH receptor antibodies, a previous neonate with Graves' disease. And when should it be done? It should be ideally done at 22 weeks. Now, very interestingly, in this mother, I mentioned that this mother's TSH was low, T4 was high, the mother had thyrotoxicosis, and I mentioned that the mother was treated with antithyroid drugs. But interestingly, when this baby was born, the baby had hypothyroidism. The baby's TSH was 28, the free T4 was low, the goiter was not there, and interestingly, the baby's TSH receptor antibody was also positive. I treated this baby with levothyroxine for a few months and stopped it. So interestingly, friends, ladies and gentlemen, the TSH receptor antibody, the TSH receptor antibody binds to TSH receptors on the thyroid gland and makes it produce more and more hormone, and that's how Graves' disease occurs. But the TSH receptor antibody has got two epitopes. It's got a C terminal and the N terminal. When the antibody is against one terminal, it causes stimulation. And when the antibody is against the other terminal, it suppresses. So sometimes the TSH receptor antibody can cause Graves' disease. Sometimes the TSH receptor antibody can cause hypothyroidism. It depends on whether it's a stimulating antibody or a blocking antibody. So here, sometimes these antibodies are likely to change as well. So what could have happened in this patient where the mother had TSH receptor antibodies and hyperthyroidism, and the baby had TSH receptor antibodies and hypothyroidism? So possibly the mother may have developed TSH receptor antibodies which are blocking, and this could have gone on to the baby, and the baby may have got temporary hypothyroidism, and that's why it all settled. It's also possible that, transient hypothyroidism of the newborn is very common. It may have nothing to do with the mother. It may be a chance effect. The third possibility is that the propyl thiouracil given to the mother may have crossed over to the baby, causing fetal hypothyroidism. But fourth possibility is that propyl thiouracil given to the mother may have got maternal hypothyroidism, and this may have gone to the fetus. But remember, the fetal thyroid gland develops after 3 months. So fetus has enough thyroid after 3 months. So maternal hypothyroxemia will not go and affect the baby at delivery. So the likely possibility in this case is that the mother had developed TSH receptor blocking antibodies after developing initially stimulating antibodies. These antibodies may have gone on and reached the baby, and the baby developed hypothyroidism. And these antibodies last for only 3 months. So it was a temporary transient hypothyroidism which got better. So coming back to the last slide, I won't prolong the agony. This is my last slide in my presentation. So in this picture, you can see Nargis Dutt looking distinctly thyrotoxic, if I may use the word, of course, not evidence-based. Here she looks hypothyroid. So is this, postpartum hypothyroidism that has happened? I won't comment on the two gentlemen sitting there and how they look. But I think Mother India is one of my favorite movies because it has a lot of important messages, including a very patriotic message, women's empowerment, etc. But here, again, I want to indulge your time a little bit. So you can see the goiter. And in one scene in Mother India, the mother, because there's no food in the house, the mother goes to the back of the house, pulls out some roots and gives it to the children to eat. So my guess is, could those roots have contained cassava or thiocyanate, which is a goitrogen, and could that have played a role? Again, it's all theory. It's not evidence-based, but just to lighten the mood a little bit in these bleak times. Yes, so we mustn't forget that iron deficiency is gone away. We mustn't forget that iron deficiency is still there in some pockets. We mustn't forget that iron sufficiency is there, but there is a increase in autoimmune thyroid disease. And we mustn't forget the role of goitrogens, the urinary thiocyanates, which may be associated with the residual goiter even in the post-iodization era. So friends, I've introduced my case of the very common nature of all thyroid diseases: hypothyroidism, hyperthyroidism, goiter, autoimmune thyroid diseases commoner in women. I showed you 2 cases, and it's been a real pleasure spending this morning discussing thyroid. We are near World Thyroid Day. Just a few weeks ago was the Hashimoto's Day. And Hashimoto, Hikaru Hashimoto, who discovered Hashimoto's thyroid disease. After discovery, he went and worked abroad in the West for a few years. He came back to his hometown, worked as a family physician, did house calls, used to go to patients' houses. And on one of those house calls, he developed an infection. We don't know what the infection was. People say enteric. And he died because of an infection he contracted during a house visit to the patient. So that's the story of Hikaru Hashimoto, who discovered of Hashimoto's thyroiditis, and the story of infectious disease, very relevant in today's pandemic. Once more, pleasure to be here. Thank you for listening to me, and